Not sure where that sound button came from. And kind of got ourselves ready for the next deployment. And that's probably fairly typical. And then again, the unending paperwork. Okay, so let's shift gears a little bit and talk a little bit about the medical aspects, the basics of the medical aspects of urban search and rescue. And again, later this afternoon, we'll talk more in detail about CRUSH. So there's this new field called Confined Space Medicine. Again, I don't know where this definition came from. I can't give attribution to anybody, I'm afraid. But it's essentially the concept of how do you provide medical care in these circumstances where you've got limited access to the patient, unsafe circumstances. This picture here, which I may not be projecting too well, is from Oklahoma City. This is a slab of concrete. You've got two rescue guys here, and up underneath the concrete, kind of up this away, is where the victim is. They can't physically reach the victim yet, but they know the victim is there. They can talk to the victim. The victim's awake and is conversing with them. So even though they can't touch the patient yet, they can already start gathering some information about the patient. How old are you? What medical problems do you have? What is, are you physically pinned somehow? Or are you just stuck in an area that you can't get out? What kind of injuries do you have? Basics like that. There's two different ways to look at this. Mostly what you think of in urban search and rescue is a structure that was supposed to be in one way and now it's in another way because it's collapsed. But this also applies very well to things like power vaults, grain silos, people that get into circumstances they don't belong in. We have a whole system of confined space permits, and I've actually seen some here in Australia too. And the reason I bring this up is that about a third of the victims of these type of events are would-be rescuers. They'll see that somebody is trapped in a fill-in-the-blank, grain silo, power vault, and well-meaning they'll rush in to rescue them, and they'll be overcome by, usually it's an atmospheric problem, a low oxygen situation, which is what caused the victim to be in trouble in the first place, and then you get additional victims. We'll talk more about that in a second. So why is it hard to do this? Well, it's kind of obvious reasons. I mean, there's no rocket science to this. If you're working in a big rubble pile, lighting, ventilation, just the physical hazards of the sharp edges and rebar hanging down and whatnot, you need some level of personal protective equipment. We discovered fairly early on that typical firefighter, what we call turnout gear, the typical structural firefighter gear is not terribly helpful in these circumstances. It will protect you fairly well from things like sharp edges, but it's just too bulky and heavy, and it's just not very practical. So we wear actually something that's a lot closer to sort of an overalls or coveralls like the ambulance uniforms here. The other concern with a lot of these circumstances, if you're talking any possibility of terrorism, is now you've got all these crime scene issues. And particularly back home, this is a huge deal with the whole war on terrorism. This again is Oklahoma City. This is DEA, Drug Enforcement Agency. This is one of the Phoenix Fire Department Urban Search and Rescue Team rescue guys, but this guy down here is with the Federal Bureau of Investigation, the FBI. And because we were pretty confident that this was a terrorist event, every piece of rubble that was pulled out of the Oklahoma City pile as they worked to get to the victims had to be physically looked at by somebody from law enforcement, whether it was DEA or FBI or the Oklahoma City Police or somebody, because they wanted to see if there was any possibility of useful evidence on it before it got chucked aside. And that really slowed things down. So now you've got a little bit of a friction between the law enforcement guys who are looking to preserve evidence and the rescue guys who are not interested in taking the extra time to do that. And you see these things in regular events as well. I've been to scenes where the needs of the police department will conflict with the needs of the EMS crew, and we see these just sort of on a bigger scale. So again, keeping in mind the atmosphere issues, if you're not crushed or mechanically injured in one of these events, almost everybody else who gets killed in them dies for atmospheric reasons. Maybe an oxygen deficient environment, could be a hazmat problem. The rescue tools that we're using are generating carbon monoxide, something to think about. And then there's also things like the risk of the secondary collapse. If you watch some of the news video footage from Oklahoma City, about 15 minutes into the event, a rumor started spreading that there was a secondary device that had been planted by the perpetrators to injure the rescuers. Everybody would converge on the scene, fire department, police department, EMS. They'd wait till a critical mass of rescuers are there and then blow up the building again and see how many of the rescuers they could take out. Turned out not to be the case, and it rarely is. But it kind of makes sense. I mean, that's the way the terrorists might think. So you've got this video shot about 15 minutes in of everybody sort of running away from the scene until they could kind of figure out was there any validity to this. So you got to think about those issues. And even if that's not the case, earthquakes, aftershocks, additional things coming down on your head, things to think about. The key thing to remember in these circumstances is the trauma approach that we teach in the U.S., the scoop and run, don't spend a lot of time on scene, get them to the hospital, just plain won't work. You've got, again, you saw I mentioned with the confined space simulator, about a 3-hour process of getting into the simulator, getting to the victim, stabilizing and packaging the victim, and getting them out. It's at least that long when you're doing this in real rubble. The first large-scale drill that I did was in Harrisburg, where we collapsed a 13-story concrete building because they were going to rebuild a part of the city. So we made a bunch of hose dummies. You guys know what hose dummies is? You take old fire hose and you kind of fan fold it back and forth, and you kind of make it look like a person. You wrap duct tape around it, the universal solvent duct tape. You spray paint it orange so you can find it, and you put it somewhere in the building. We put 13, 14 dummies in the building, collapsed the building, and in 2 days we found 4 or 5 of them. It was really kind of embarrassing. But I will tell you that it took hours to do this process. Even if you have a fairly good idea of where somebody is, you know, somebody gives you some intelligence, there was somebody in that stairwell over there, I think you'll be able to find a victim there, which is what they did for us. They kind of cheated a little bit and gave us some hints on where we might find the victims in this collapsed building. The process of getting in, freeing them up enough that you can get them out, packaging them, starting an IV, you know, basic stuff like that, and getting them out, it was like a 4-hour deal. And I didn't believe this at all. I'm like, oh, come on, it's going to be like half hour, 45 minutes. We'll zip in, we'll get them, we'll yank them out. It takes a whole lot longer than that. So the general principles of get them out, have them in the ambulance, take them to the hospital, it's just not going to work. So you have to sort of shift your mindset a little bit to dealing with a patient on sort of a longer term basis. So how does this actually work? Well, you want to provide some stabilization. We'll talk a little bit about more in a second here, but there's a lot of other things you can do for the patient in addition to just stabilizing them a little bit. For example, the less immobilization, the better. If you're going to put somebody on a long spine board to try to get them out, you're just making it a lot harder for the rescue guys. That just makes a lot more work for them. Simple things like pain control. If I can manage the patient's pain, rehydrate them a little bit, reassure them, maybe they're going to actually be able to help me get them out a little bit instead of me just having to drag them out. You know, is it okay, hey doc, is it okay if I kind of, you know, move this arm looks busted, but I think I really kind of need to move it to get this guy out. Can I tuck that arm under? Things like that. They'll come to you and ask you for some sort of anatomic advice like that. And what information can I gather about the patient if I'm going to be able to hand them off to EMS? What can I learn about the patient that might be useful for them? And then again, this afternoon we'll talk about renal failure and the more detailed clinical issues. I'm going to kind of skip those for now. While we're working in the rubble, obviously the chances of getting injured are pretty high. So one of my responsibilities on medical is to make sure that everybody on the team has got all their protective equipment. And this is sort of the typical uniform. It doesn't project all that well, but it's just sort of a heavy jumpsuit, kind of like a flight suit, a Nomex flight suit type thing. Helmet, if there's any possibility of respiratory issues and we need cartridge masks, and which cartridge do we pick? We got a whole box of different cartridges. What do we use depending on what we think the hazards are? Obviously, eye protection, hearing protection is very important because there's a lot of tools running and making a lot of noise in the area. A couple of flashlights. I've got a helmet light. I've got one on my belt, and then I got a mini mag in my pocket just as sort of my third backup just in case because it's pretty dark in the rubble pile. Knee and elbow pads. You're just going to be crawling around in the rubble for literally hours, and it's nice to have that protection there. And while the rescue operation is going on, their primary goal is, let's take the building apart and get to the victim. So they're going to be creating dust. They're going to be creating carbon monoxide from their equipment. They're going to be moving things. And I've got to think about what is the impact of that going to be on the victim and on our personnel. So, you know, that hearing protection is important, but then you can't hear what's going on the radio, or you can't hear your team leader yelling instructions at you. So you'll find guys have pulled their earplugs out for a while. You got to sort of keep an eye on these things. Once I get to the patient, I want to be able to protect the patient a little bit. So we've got a kit all made up and ready to go, about yay big, that has the basic stuff in it that I'm going to need to protect the patient. It's a helmet with a bunch of stuff stuffed in it. And if there's enough room in there that I can put the helmet on the patient so that if there's further collapse or I'm moving them around on the way out, I can protect them a little bit. A simple dust mask. We're not talking cartridge respirator, but basically, like an emergency department or operating mask. Goggles so they're not getting more junk in their eyes. Hearing protection for them so that their hearing isn't affected. Some wet gauze so I can get dust and junk out of their mouth if I can. And a collar if I'm going to need this to immobilize their neck. So with just that package, which is fairly small, I can at least protect the patient a little bit hopefully from further harm as we work to extricate them and then drag them out. Taking off jewelry so it doesn't get further, pinch the skin, whatever. All those things I'll do as soon as I get there. And what I want to do is immobilize as little as possible. Again, the harder it's going to be to get them out, the more you immobilize them. So I'd like to avoid using a long spine board. Maybe I'm concerned about the neck, but their back is fine. I can use some sort of short board, whatever the circumstances are. And rigging is fun, and it's nice to play with all the toys and all, and the tech guys like to do that, but it really makes life a lot more difficult. So the less immobilization you can do and the more help you can get from the patient. Maybe the patient's legs are completely uninjured. They can kind of help push themselves out. Great, go for it. Anything you can do to kind of make it easier. Frequent reevaluation, and we kind of do this in regular EMS, but you're kind of, typically, at least in my neck of the woods, we're thinking of, 10 to 20 to maybe 30-minute transport time, so maybe I'll check a second set of observations while I'm on the way in. You're going to be with these guys for a couple hours while you create a path for them to get out, get them packaged, and physically move them out of the rubble. So frequent vital signs checks, just talking to them, hey, how you doing? We're making good progress here, don't worry, we're going to get you out of here. Doing that fairly often as you go along. And every time you do something substantial to move them, let's say we've made a 50-yard drag or 50-meter drag, through the rubble, and now we've got to turn a corner and do a vertical hoist, whatever. Stop, reassess. Is there anything I can do to stabilize them a bit more, or maybe some bleeding has restarted, something else I need to do, maybe some more pain meds before we do that vertical hoist. Again, the rescue guys, rightly so, I'm not saying that this is wrong, their focus is on getting them out, because that's what they do. So you may have to say, all right, just give me 2 minutes here, guys, to reassess this patient. I think the leg's bleeding. Let me rebandage that, whatever. Give them a little more morphine before we do the next move. And if you explain why you want to do it, they'll be fine with it. It's no big deal. That's an important part of the whole training part, too. It's a little harder when it's a hose dummy to say, well, I want to give them more pain meds and all. But if you do the same thing and say, all right, let's just stop for 30 seconds. You guys figure out how we're going to do this vertical hoist and give me a minute to reassess my patient here. And getting that rapport going and getting them to understand why the medical pieces of this are important during training is going to pay off later. A lot of the stuff that you're going to see on the patients is stuff you see every day. They're going to have lacerations because something fell on them. They're going to have a head injury. You guys know what to do with this stuff. There's nothing unusual about it. But there's a handful of things you don't typically see in sort of, let's call it civilian EMS and emergency medicine practice that you may see that you need to know a little bit more about. So we have a whole 3-day training package for the medical team members that focuses mostly on these unusual aspects. We kind of assume they know how to start an IV and bandage a laceration, but maybe they don't know a whole lot about dust airway impaction and some of these other clinical things they don't see all that often. So we'll give them some extra training on that. Dust is an amazing problem. When we collapsed that building in Harrisburg, they collapsed it at 6 o'clock in the morning. We were still at our air base about half an hour away. Even within it took us about an hour to get our stuff ready and get over to the site. There was still so much dust, we couldn't see a thing. And it just wasn't worth starting the exercise for a couple more hours until the dust settled down to where we could see what we were doing and not have to be wiping our glasses off every 20 seconds. So the dust that's involved, particularly this was a concrete building. And again, depending on what the building is made of will determine what the dust is. But it's a huge issue. In the Kobe earthquake in Japan 10 years or so ago, I'm told, I don't have actual numbers, somebody told me though that more people died of dust airway impaction than of physical trauma. I'm not really sure I buy that, but clearly there were hundreds of people who died because of respiratory compromise from all the dust that was involved because of the type of construction that was in that city, and I don't even really know what that was. So something to think about. The other respiratory problems are probably things that you're fairly familiar with, though it may just be something like they're physically squished and they can't expand their chest as much as they need to. So essentially it's sort of a mechanical hypoventilation kind of issue. Pneumothorax and hemothorax, in the field you may needle decompress, attention pneumothorax, but if you're going to be in the rubble pile with this guy for 3 hours while we're working to get him out and they've got a chest full of blood, yes, placing a chest tube in the field may be your best option because sticking a needle in is not going to do it for you. So you may actually need to place a chest tube in the rubble pile if that's what it's going to take to get that lung re-expanded. So these are just additional things you kind of need to think about beyond your everyday EMS practice. Inhalation injuries, we talked